Okay, so we are at 12:29, so I might as well get started. So for those of you who are online, thank you for coming, and hopefully I'll cover virtually everything you ever wanted to know about joint replacements in the year 2020. It's a pretty common procedure these days, as you know. Just a few comments about myself. Who the heck am I? Why am I talking to you? Why should you listen? Why should you waste your time? My name is Jonathan Garino. I am a joint replacement surgeon at Premier Orthopedics in our Pennsylvania Orthopedic Center Division, which is across the street from Patella Hospital, is our main office. And we have a few other offices in Montgomery and Chester County. I got my training initially in medical school at Georgetown, went to New York for my basic orthopedic training, was fellowship trained in adult reconstruction, which is joint replacements at the University of Pennsylvania long ago. I'll just leave it at that. And spent 18 years at the University of Pennsylvania on faculty where I trained residents and fellows and ran their adult reconstruction program. I came over to Premier about 10 years ago. Some of my credentials include the inventor of the journey knee, and I've written well over 100 scientific papers in the area of joint replacements and either the diagnosis, treatment, or techniques of performing those surgeries. So that's a little piece on me. So first question, of course, that everybody asks is, hey, my hip or my knee hurts. Do I need a knee replacement or a hip replacement? So I'm not going to spend a lot of time talking about, those folks who are in the midst of conservative treatment. Suffice to say that there are a number of conservative treatments, including cortisone, anti-inflammatories, physical therapy, and they all, have their role. We have also some other fancy injectables known as viscosupplements. You may know the brand name of one of them is Synvisc. They come in a variety of different forms. There's a variety of different brands, but they're another material that has shown some efficacy in decreasing the pain in joint replacements. We don't do a lot of injections in hips because the hip is difficult to get a needle into exactly unless you do it under X-ray or ultrasound. So we find that doing a lot of injections for hips is not terribly effective or practical. So we don't typically use a lot of those things in hips that are symptomatic. Stem cells and PRP, you've probably seen or heard a lot about stem cells and PRP, and the jury is still out on those things. If they worked very effectively, for sure your insurance company would pay for it because your insurance company wants to save money, and something that's a few $100s or $1,000 is a lot less expensive than a joint replacement. Unfortunately, the results are way too variable. And for some people, they work great, and other people, they don't. And we're still trying to figure out what is the best mechanism for using it, or the best indication. For now, if you have the resources and you wanted to try those things, the risk is very low because we're just taking material from either your vein or from inside your bone marrow, spinning it down, adjusting it in certain ways, and then injecting it into the affected area. So the risk is very, very low. The benefit is unknown, and there is a little bit of risk, obviously, financially, if it doesn't work because you've spent this money and you didn't get the outcome. So, but once you have exhausted all of those conservative treatments, and everybody's a little bit different, activity levels are different, weights are different, terrain that people work in, their jobs, all those things have an impact on whether or not these, how long do you push these injections or the anti-inflammatories of the therapy? And it really becomes a personal choice of what that person is willing to put up with, because it interferes with quality of life. And some people can tolerate a certain amount of reduction in quality of life better than others. Ironically, highly active people have a tendency to get their joint replacement a little bit earlier because, they are having trouble staying highly active, playing tennis or squash or things like that. So they have a tendency, if the writing is on the wall that they're going to need a joint replacement, they have a tendency to perhaps pull the trigger a little bit earlier. If we get to the point where we agree that you've exhausted your all conservative treatments, anything that's experimental and whatever, and you've made your decision to move forward with a joint replacement, that's really where our session begins today. I will add that, again, that's a very personal decision, but keep in mind that we do somewhere in the vicinity of 500,000 total knees and 500,000 total hips. Actually, we do a little more knees, roughly. So we're doing about 1 million joint replacements a year in the United States. So there is a finite limit to the conservative treatment, at least the conservative treatments that we have today. That once you've got a bad looking joint that's painful, we can only get you so far with these conservative treatments, and then you're going to need a joint replacement. If you look at the back of the handout, you can see some x-rays that we have for some individuals who have had x-rays of bad knees and x-ray of particularly a bad hip. You can see the other hip is a little arthritic, but you can see that there's still a little bit of a joint space there. And you always hear the term, I have bone on bone. So obviously, if you see someone walking down the street, you can't tell that they're bone on bone. So when we're talking about bone on bone, we're talking about an x-ray description. And if you look at those pictures, you'll see on one side, if we talk specifically about the knees, we'll see a space on the outside between the two bones. And then on the inside, we see the bones are touching. And so on the inside, we have bone on bone. On the outside, we've got a gapped open space. So the space represents cartilage. And X-ray goes basically through cartilage like air. And so if you've got space on both sides between the bones, then you've got cartilage. As the cartilage wears away, the space becomes smaller and smaller until all the cartilage goes away, and then you've got bone on bone. Now, as things get worse, the bone starts to deform, it creates spurs, and so there are, spectrum of how these x-rays look in terms of severity. And if you look at the hip x-ray, that's one that's pretty severe, where there's a lot of deformity of the femoral head and a lot of osteophytes, and clearly there's no space, and that hip probably has extremely poor motion. And then once you've decided that you want to move forward with hip replacement or knee replacement, then we start the process. So in our realm of the world, we like to do 3 things before surgery. One, of course, is to get medical clearance. Medical clearance is very important. So once you've decided that it's a good idea and you've picked the date in your schedule, and as far as scheduling is concerned, we're going to talk about some of the details of the recovery coming up, but there's never a good time to do a joint replacement. So you really want to look toward a period of time where you have anywhere from 3 to 6 weeks where it's a slow time if you're working, or and if you're retired, if you like to play golf, and maybe the winter time is a little bit better, for example. So one of the questions that I see over here is, when will elective surgery return? I started talking that a little bit before time, so let me bounce back really quickly. We don't exactly know. The hospital in the next 2 weeks is going to ramp up with limited outpatient surgery, and then slowly expand the volume in the operating room and the complexity of cases. So we're looking for joint replacements probably, early to mid-June, and then hopefully we're at full capacity doing what we normally do sometime in July. And unfortunately, we have to, for the folks that are thinking about a replacement and haven't gotten in our queue, it's going to take us a little bit of time to deal with the backlog because we're going to be going at a slower pace than normally. So, and that's sort of the commentary. So about getting back on track. So hopefully it'll be sooner than later. But it's a little bit of a moving target. Things go exceptionally well, they may speed things up. If there's a big spike, then they may slow things down again. So we will see. But as of right now, based on the information I have, early June, mid-June for us to get rolling again. So medical clearance, very important. We operate on a lot of older people. Older people are people over the age of 60. Takes most people a lifetime to wear their joint out, and that's really why it's a problem mostly of older folks. And I use that word pejoratively. People again over the age of 60. Certainly there are a number of younger people that have been in accidents or have bad genetics, and they're candidates for joint replacement. But because once you get to 60 and beyond, it's rare that we're finding patients that don't have any comorbidities, whether it be diabetes, obesity, some kind of heart problem, et cetera, et cetera. So many of them are managed, and if they're managed, that's obviously great because that's what we're interested in, these medical problems that are being well managed. And so the medical doctor has to weigh in and help our friends from anesthesia do what's known as risk assessment as far as the surgery is concerned. Now, fortunately, the procedure today has become a little bit more of a commodity procedure, meaning the number of people are doing them. And as I told you, we're doing literally 1 million plus in the United States every year. So that's a lot of joint replacements. And two things that have happened, and I'm going to talk about them in a little bit more detail, that have made joint replacements really much more much easier on the patient are our ability to reduce the blood loss significantly and our ability to manage pain. So those two things really over the course of the last 10 years and certainly ramped up over the course of the last 5 years have really been game changers in terms of joint replacements. The history of joint replacements, I'm going to digress a little bit. We went through this period of time where people would come in the night before, they would have their surgery, they would spend a week in the hospital. This is back when I trained in the 90s, and virtually everyone would go off to rehab for another 2 or 3 weeks. So they would be gone virtually a month at a time. We really were very careful about the patient, not letting them bear weight on it, and just moving at a real slow, careful pace. And when you do that, the problem of deep venous thrombosis was a lot higher back then. Not to say that it's not a problem now. I'm going to cover that a little bit. But those are some of the evolution. We used to also have patients donate their own blood because the procedure used to be much more bloody. And then we would give them their own donated blood back. And we don't typically do that anymore. So once you've completed your medical clearance and everything is all buttoned down, you have to do obviously pre-admission testing. That's a part of it. And we typically like patients to do a session of physical therapy before they come to the hospital. And we refer to it affectionately as prehab. And it's really just another educational session. So at least for me, the session that you have with me at the time of surgery will review the risks and the benefits of the surgery and the process. The handout, which you have a copy of, which is 9 pages long and really goes into a tremendous amount of detail, blow by blow, and really kind of answers a number of the questions along the way. And then you'll get the perspective from the physical therapist. They let you know what you're going to need to do, how you're going to progress with assistive devices. And they provide a tremendous amount of safety information on how to prepare your home for after surgery. So once all of that is completed and you've picked out your date, then you basically show up in the operating room. And we've completely vetted everything, and we've decided what we're going to move forward with in terms of your primary hip or knee replacement, making sure there's no special circumstances, like a previous traumatic event with orthopedic hardware, or if you've had a dysplasia, some congenital kind of issue that has altered your anatomy that requires us to use special kinds of implants. Patients who have had previous trauma, particularly the knee, they may have had ligament injuries, and so we plan for knee replacements that I refer to as heavy duty or constrained, because they help to compensate for any ligaments that are less than perfect. As I said, the two things that we do very well are blood management and pain management. We typically use a medication now called tranexamic acid. We give that before surgery, and that works on the clotting cascade, particularly the fibrinogen area of the clotting cascade, and really is very effective at sort of plugging the holes as we make our incisions to stop the blood from leaking out. So by doing so, we've really reduced our transfusions. I would have to say that maybe only 5% of our patients are transfused these days, maybe less. And those are patients who are not anemic. If you're anemic, even some of the anemic patients, they're not getting transfused either. It all depends. We don't have any specific triggers in terms of how low you can go. Depends a little bit on your age, your comorbidities, and whether or not you're symptomatic. Are you getting lightheaded when you're getting up after surgery? So those are the things that make a decision as to whether or not we're going to transfuse you. But the transfusion rate is really pretty low, and it's almost always done the day after surgery because we want your system to equilibrate. So if you lose any blood, we fill you back up, or that deficit of blood loss with salt water in your body usually can make that adjustment pretty well. And so we see how you do the next day. Sometimes we give you a little bit more salt water, a little bit more saline before we rush off and do transfusions. We really don't like to do transfusions. There's a lot of downside to giving folks transfusions, but we'll do it if necessary. As far as pain management is concerned, we have a fairly extensive protocol, and we refer to it affectionately as a multimodal pain management protocol. And we do a lot of pre-medicating. We give a little bit of narcotic before surgery. We give some steroids before surgery. We give anti-inflammatories before surgery. And we give a few protective medications for your stomach to make sure that you don't have any reflux or any gastrointestinal issues after surgery. And then we do the surgery, and then intraoperatively, when we finish, we typically give the patient or the area around there fairly extensive injections of long-acting local anesthetic that's diluted. So when we do that, coupled with the pre-operative administration of these multi-modalities, and then post-operatively more steroids, more anti-inflammatories, and very judicious use of narcotics, making sure that your pain stays at a 5 or less, it's been really effective. And the trick is really getting patients through the first night. Patients get through the first night and they kind of sleep okay, and they don't have as much pain as they thought they were going to have. We've kind of broken down that anxiety barrier. Then we're in pretty good shape. The next day, the patient, once they're awake and alert and they're starting to use their hip or their knee, they really feel pretty darn good, and then we can adjust the narcotics. We're using probably compared to 10 or more years ago, where we were almost exclusively controlling pain with narcotics. We're probably only using 25% of the narcotics that we used to use. And narcotics, generally speaking, are bad. I don't have to really go into a great deal of depth about that, but there's just a lot of side effects, between nausea and constipation and lightheadedness and funny feeling. Most people don't typically like them, but On the other hand, it's very difficult to get through a joint replacement without using them, at least on a very limited basis, whether it's the first few days or a week or so. And so, for those of you that are out there and have a particular viewpoint or attitude about narcotics that you really want to stay away from, it's a very good attitude to have. But keep in mind, it's pretty difficult to really do or recover from a joint replacement without some mild level of narcotics. And so you just need to manage it like anything else, moderation, and then as your pain improves over the course of time, you use less and less of it. Hip and knee replacements, they roughly take about 45 minutes each. Knee replacements, we do them with a tourniquet. The approach is what's known as a parapatella or median parapatella, which means we make an incision next to the kneecap and we move the kneecap out of the way and off to the outside part of the knee. And then that allows us to do the work. And again, you can refer to the pictures. There's a couple of pictures that show you how we make these bone cuts, and then we put these components on. People are always wondering about the size of things. The traditional way of doing a knee replacement is to make some basic cuts using instruments for alignment. In other words, if you have a knee that's bow-legged or varus, we're not gonna use a cutting tool that's parallel to the joint line. We're gonna use a cutting tool that is some degree off of the shaft of the bone, because in areas where the bone has been worn away, when we make our cut through that area, the bone cut is going to be actually very thin in that area, but then we're going to put a much thicker piece of plastic or metal there to build that side back up again and restore the normal configuration of the bones. The normal configuration is about 5 degrees of valgus. Valgus means knock-kneed, and believe it or not, we're all a tiny bit knock-kneed, about 5 degrees. And that has everything to do with the anatomy of the hip, because the femur bone doesn't come straight down from the socket. It actually goes out a little bit. And so since it's pushed out a little bit, it has to come back in. And then that angle that it makes with a tibia, which is the lower leg bone that's straight up and down, is roughly about 5 or 6 degrees. And so we like to match that. And that's what we typically do. And then as far as size is concerned, once we make our initial bone cuts, we have the ability to size things. And it's kind of funny. It's almost like going to a shoe store. You have a particular implant that we use, and we have inventory that we maintain. And once we measure it, we know that normal anatomy is, with at least the system that I use, is between a size 2 and a size 9 if you happen to be a very large person. Size 1 and size 10 is available, and custom sizes are available too if you're operating on, Shaquille O'Neal or some other Andre the Giant or some other large individual. And by the same token, the sizes can be pretty small, so we can operate on dwarves or other individuals that are very small stature. So we don't typically do a lot of these measurings ahead of time, because we have this vast inventory that covers the population very well. Except for those, individuals on the extremes either side. And there are some doctors that do templating. Templating is a little bit more common at the hip, where the sizes are sort of mapped out on x-rays, or we have all these digital things on computers where you can lay the size of the implants and get a sense of what size you're going to use. In some ways, it's a little bit of a moot point, because once you've made the bone cuts, then you can actually measure while you're there. Knee replacements, they are done in my hands primarily with cement, or exclusively with cement. Cement has been used since knee replacements were started over 50 years ago. And over the course of time, special coatings, we call them porous coatings, have been applied to the back surfaces of knee replacements. And since the cutting tools that we use are fairly accurate. You can really press these parts on fairly tightly. And when that happens, you can use cementless devices. And some doctors they like to use them in younger patients because it helps preserve the bone stock and the bone quality a little bit better because the bone is more actively involved in taking on the stress. It's a little bit controversial because unfortunately, occasionally you have to take a knee replacement out, and taking out a knee replacement that has bone growing all over the back side of it is a little bit more difficult. And so you can end up with a little bit more bone loss. Moreover, cementless knee replacements haven't quite reached the point of fixation success as cemented knee replacements. What does that mean? It means that cemented knee replacements, generally speaking, they don't come loose that often. And so that's why there hasn't been a big migration over to cementless knee replacements. They're also a little bit more expensive, and that's something that we always keep in the back of our minds because the cost of things is always important. Hips is kind of the opposite. They were always cemented throughout the 70s and 80s, and there was a slow move toward using cementless implants. Cement in the hip, because of the way it gets pressurized, would cause some complications. So there was a secondary reason to move away from cement. The way the cement from a mechanical standpoint was working in the hip was different than in the knee. In the knee, it's almost like a glue or a grout, whereas in the hip, it's really part of the whole supporting structure. And the cement would ultimately crack and become a bit of a problem. Now, over in Europe, probably the vast majority of hips, maybe 60, 70%, particularly in patients over the age of 70 for sure. Virtually all of those are cemented, and they do very well. We understand the design of hip replacements with respect to cement, and have been very successful. Here in the United States, we probably 90% or more of hip replacements are done without cement. And even in older folks who have osteoporosis, because we have implants that are designed to work with them. If you look at the further down the handout, you can see that there are pictures of some of the knee replacements and some of the hip replacements that we use. I like to use the Journey knee replacement from Smith & Nephew and the Co-Rail or Karai hip replacement from DePuy. The Karai hip replacement has celebrated a 35-year anniversary, so that stem, which is covered with hydroxyapatite, is 35 years old. So that changed very little. Has an excellent track record. And I like to use, it's not pictured there, the one with the collar. And the collar is helpful in patients with osteoporosis. So once we finish the procedure, there's always questions about, well, as far as the hip is concerned, should I have an anterior approach or a posterior approach? And I would say the following. At the end of 6 weeks for sure, there's no difference if the procedure is done well. At 3 weeks, they're pretty much the same also. But there's basically three main approaches. One is the posterior approach, one is the anterolateral approach or Harding approach, and the other is the direct anterior. The direct anterior is something that's relatively new. It's been around probably about 15 or more years, certainly 15 years it's become popular. And in my opinion, there is not a huge advantage of that procedure over posterior approach. I'm not a big fan of the Harding approach or the anterolateral approach because you have to take off part of the abductor muscle and then reattach it. And if that doesn't heal well, then the patient has a little bit of a limp, and they don't like that. So we try to avoid I try to avoid that approach, but it's still a pretty popular approach. And if the abductor muscle attaches pretty well, the results are very good. As we compare the anterior to posterior, both can be done through mini incisions, and both patients get the same basic multimodal pain management protocol, and off they go. The posterior approach does not cut any muscles. There is a splitting of the gluteus maximus muscle, is the only muscle that is addressed at all during surgery. And because the incision is small, the split is not very, very long. And if you're splitting along the line of the fibers, when you sew it back up again, it basically comes back very nicely. The anterior approach, one of the problems with the anterior approach, there's two problems from my biased perspective. I like to do the posterior approach. It's a lot easier to break the femur, or I should say it's a lot harder to put a femoral component in. There'll be, some people that don't agree with me, especially the ones that do them all the time. There's a learning curve, et cetera, et cetera. And then there's a lateral femoral cutaneous nerve, which is a pure sensory nerve that's nearby. And if that gets injured at all, it can really give the patient a fair amount of pain, and it's really hard to treat. So those are the two downsides. Posterior approach, of course, has been associated with slightly higher dislocation rates, which I think is pretty much under control now. And really that's about it. So my patients, post-surgery, they spend a little bit of time in the recovery room and then off to the floor, and we usually have them walking the same day. On a few occasions, patients who are really motivated, they can potentially leave the hospital later that day. They don't have a lot of pain. They've cleared physical therapy. And when we say clear physical therapy, we're looking for them to do four things: get out of bed by themselves, and out of the bathroom by themselves, negotiate some stairs, and walk 100 feet. And if the patient can do all those things pretty well, then we're pretty comfortable sending them on their way. Otherwise, they'll spend the night, do those things the next day, and more than 80%, 85% of our patients, we take all comers, leave the hospital the next day and go home. The others, the vast majority of those will spend another day because it's just not quite ready, a little too much pain or some other, minor side effect, minor medical problem. And then they'll clear the therapy the next day and then go home. Nowadays, it's pretty rare that we send folks off to any kind of skilled nursing facility. Most rehab places will not take standard joint replacements because they're just not going to spend that much time there. Not like the old days where we would routinely send them there. So we really are pushing very hard to get people home. And we found out that home is the best. And why is it the best? Well, we find that if we send folks to skilled nursing facilities, rehab facilities, they're obligated to really work you hard and have a regimen of exercises that therapists typically like to do. And that's a little bit hard to do a day or so after surgery. So our protocol has changed, and we basically just want you to take care of yourself. That's your rehab for the next 3 weeks. In that bed, go to the bathroom, make a sandwich, go to the mailbox, water the flowers, basic kinds of things that you will do for roughly 3 weeks. So for those that are wondering, hey, when do I get back to work? The vast majority, we just really discourage you from doing very much for 3 weeks. We want pain to settle down. We want the swelling to come down. We want you to get comfortable off of the walker onto a cane, maybe onto nothing. And so generally speaking, about 3 weeks. There are exceptions to every rule, but generally speaking, 3 weeks is the rough guideline for going back to work, pretty much no matter what you do. And depending on how you feel, and I'll talk a little bit more about that in a minute. Those patients come back and see me at 3 weeks, check their wound, answer their questions, make sure everything is okay. And then usually that's when we let them drive and we start them on outpatient physical therapy. And that's when they can start thinking about going back to work. And that's that's the basic time frame. People like to play golf and tennis. They start thinking about doing those things about 6 weeks after surgery. If you have a very labor-intensive job, if you are, a carpenter or a mason, it's probably prudent for you to wait closer to 6 weeks. People who come in 3 weeks, most of them are off all their narcotics. They're typically going to continue to use their anti-inflammatories for another 3 or so weeks, maybe a little bit longer, depending on how much pain that they have. And that pretty much takes them, to the end of the road. We have patients come back at 3 months, and then again at 1 year, and then we do encourage, maintenance visits every 2 to 3 years, quick X-ray, answer any questions or concerns, make sure there isn't any early loosening of wear. I want to come back now and talk a little bit about a couple of things. First of all, I did talk a little bit about hip replacements and that they're primarily cementless. And I would say 90% of the time, there's really not a lot of variety among surgeons with respect to the kind of implant that they use. It's usually a tapered stem. It usually has coating on it, either titanium porous coating or hydroxyapatite, which is the mineral content of bone, and that helps get the ingrowth. As far as leg length is concerned, we typically measure in the operating room. I like to put a pin in the pelvis before I start the surgery, mark the greater trochanter, which is inside my wound, and measure before and after I put my hip replacement in for that particular patient, and that usually serves me pretty well in terms of making sure I match their leg lengths before and after surgery. On the cup side, the implant is pretty much the same again. A lot of success with a hemispherical cup, half of a sphere, where we have tools that ream the socket into a hemisphere, and the sizes of the socket go up every 2 millimeters. Starting as small as 38 millimeters in either dwarves or small statured individuals or people with hip dysplasia, and they go all the way up into the 80s in some revisions with bone loss. So we have a tremendous inventory of devices, and so we can pretty much custom fit the femoral component. And then the bearing surface, there's a metal bearing that has fallen out of favor. There's in Europe, surface replacements are still a little bit popular, but it's a metal bearing, so it's kind of fallen out of favor here in the United States. So we pretty much use the same socket, the same stem in all cases, same type of stem. I'll call it a sedan. They can be made by many different companies, but it's just basically a sedan. As you know, I mentioned that the hip replacement I use is 30 years old. And then you can use a ceramic on ceramic, you can use a ceramic on plastic, or you can use metal on plastic. The plastic has become quite good, and so unless you're below the age of 50, the plastic is more likely than not going to wear out in your lifetime. It's going to be hard to do. If you're younger than that, then there is a possibility because of higher activity levels and longer life. And so hard bearings such as ceramic on ceramic can be considered. In the knee, and I didn't spend a lot of time on the knee, knee replacement designs are pretty complicated. They do vary a lot more than hip replacement designs from manufacturer to manufacturer. I like to use the Journey because it's the only one that, at least in part, substitutes for the anterior cruciate ligament. All the others really don't do a good job of that unless you're talking about the very specific special knee replacement where the cruciate ligaments are actually preserved and the surgery is done sort of around them. A lot of doctors like to do partial knee replacements, and there was a question about partial knee replacement. And I used to do a lot of those. I've kind of drifted away from them, and I've done really just more or less all total knee replacements. I've done that for two reasons. Reason number one is the knee replacements are better with partial substitution of the anterior cruciate ligament. And at least philosophically, for me, when I operate on someone, I want to give them the best chance of not needing to come back to the operating room again for that particular knee. And when you only do a partial knee replacement, the idea or the possibility of getting arthritis in the other areas that you didn't resurface is pretty real. Because the tibial piece in that compartment, you can refer to the handout again, the pictures at the end. The tibial piece is pretty small, so it doesn't have this superb grip on the tibia, and so there's a higher propensity for a partial knee replacement tibial component to come loose when compared to the full knee replacement tibia, which has got a longer stem, which acts like a footing in the bone. Question about whether or not we should resurface the patella. And it's pretty much controversial. It's been controversial for a long time. Probably about 3/4 of the surgeons in the country do resurface the patella, and about a 25% do not. There's been, I think, 2 good studies where they randomized patients where half the patients, they resurfaced the patella and half they didn't to see what happens. And they both had the same amount of discomfort in what we call the anterior part of their leg, or so-called anterior knee pain. The only difference between the 2 groups is that if the patella was not replaced, the back of the patella, and you had anterior knee pain, a higher percentage of those folks went back to the operating room and got, the patella button put on the back of their kneecap. So for that reason, a lot of people feel like resurfacing the patella is a better way to go, because if you got the same outcome, at least we're not worried about the possibility of patellofemoral arthritis problem, and then you're bringing the patient back to the operating room again. So we want to try to avoid that. There is a patellofemoral replacement, which I actually like. There's a number of patients that will come in and they just have had dysplasia of their kneecap. And so they have pretty much isolated patellofemoral arthritis, which means the kneecap in the place on the femur bone where it's rubbing. And that means that that gap, or that space between the tibia and the femur, or the thigh bone and the leg bone, is actually normal. And that also means that the cruciate ligaments are normal. So this is a procedure I really like, because I'm just eliminating arthritis in that one compartment, and they have an excellent longevity. I have some patients that are pushing 30 years with their patellofemoral arthroplasties, because the rest of their knee is really great. They just had dysplasia of their patella, so the patella was unstable, was sliding around. And so that when you replace it, you put normal components in, and you kind of sort of solve that problem. So that's the device that I do in terms of partial knee replacements. I still kind of like. Those patients are pretty rare, though. And I'm going to look over here now and see if I've covered everything. And it looks like I have no outstanding questions here. So again, one of the questions: do you believe in patella replacements instead of total knee? If you've isolated patellofemoral disease, then that's a really good procedure. If the femur and the tibia, that mechanism is in good shape, there's no malalignment or deformity or arthritis, that's great, because you're not mucking around with the cruciate ligaments at all. So that's a really good procedure. So I think I've covered pretty much everything. Some of the precautions regarding COVID-19. I believe the plan is to test anyone coming into the hospital to make sure you're not bringing the disease in, because I think they're going to do their best to kind of separate areas of the hospital for COVID and non-COVID. So that's going to happen. One of the things I forgot to talk a little bit about was robotic hip joint replacement. I have in that handout a picture of the robot. I'm not a big fan of the robotic hip replacement or knee replacement surgery. And the reason why is pretty straightforward. It's just a lot more expensive and doesn't produce any better results. There's been a number of studies now, more than 10 years old now, that compare patients who have had robotic surgery, patients who haven't had robotic surgery. And although when we look at the really precise alignment of things, it's better with the robot, but not hugely better. But the outcomes are the same. There's no difference. They both have the same amount of good, excellent, fair for whatever reason. The robots are very expensive. This is how they drive up the cost. They drive up the cost because hospital has to invest in a robot, which can be quite expensive. Some of them are $1 million. And so that's an up-cost investment. The patient has to go for an extra study. They have to get either a CAT scan or an MRI. That because the CAT scan and the MRI, the images are taken in multiple planes, and when you use special protocols, you can actually do a 3D reconstruction of the knee joint. And so that information gets shipped to the manufacturer, and the manufacturer maps out a plan that the robot will use, because they go on there and decide this is where the cut on the femur should be, and this is where the cut on the tibia should be. And most of the time, most companies, they make those cuts to accommodate a certain size implant. In other words, when you have the 3D reconstruction, you know that the patient is going to use, let's say, a size 5. And so they are going to make the bone cuts virtually to accommodate a size 5 implant. It should fit pretty perfectly. And so then what happens is they produce a custom cutting block for that patient. And the custom cutting block will fit on the end of the bone, kind of like a key in a lock. It snaps on, fits perfectly. And then there's slots located and holes where we would use our saw to cut the bone and pin other cutting blocks in a very specific place, and then finish manipulating the end of the bone so that it will so that the size 5 implant will fit, for example. So robot surgery usually takes a little bit longer. Some people actually, rather than use the custom cutting blocks, they actually bring physically a handpiece, a robotic handpiece. And once you register where the handpiece is in space, then the handpiece kind of guides you, where to make your cuts. And you're usually looking at a computer screen while you're doing that. And again, I have a picture on in the handout of one of the typical robots, and an intraoperative view of docs, using the robotic handpiece and while watching the television screen. So for me, if there's no improved outcome, and there's such pressure on controlling costs, to me, to make the investment for a robot and then to spend the extra money and potential radiation on a patient, they may have another copay involved, and then to have the hospital spend the extra money on the cutting blocks that are customized. To me, it's adding cost to a procedure that's excellent. And if the cost that were added made a significant difference in the outcome, then it would be justified. But in my mind, those things are just not justified yet. Like any technology, as the cost of things go down, the turnaround goes down, 3D printing of the cutting blocks goes down. There may be some efficiencies in the future where it's maybe a break even. And if it's a break even and you're reducing outliers, then we can have a discussion of whether or not it's cost effective to do those things. There's a lot of folks that believe in them, very much so, and the orthopedic companies are very keen on using this technology to make things better. The problem is the implants really haven't improved or made any significant improvements over the course in hips the last 30 years, and in knees, let's say the last 10 or 15 years. They're all roughly about the same. And until they change and they actually produce a more normal knee, I'll use the word kinematic. Kinematic means the way that the knee works. Until a new knee replacement really reproduces the kinematics of the knee, all this extra technology is really not going to change the outcome. This technology may be very important for reproducing knee replacements when the kinematics are better. And I'll give you the one example. Virtually every knee replacement that's done, the anterior cruciate ligament is cut and not replaced. In the vast majority of knee replacements, when I say vast majority, meaning like 55, 60%, the posterior cruciate ligament is also cut, but it is substituted fairly successfully in most knee replacement designs. So when you basically are taking an arthritic painful knee and you get rid of the pain and the arthritis, but you take away the anterior cruciate ligament, you're returning to that patient a knee that's much less painful, but somewhat unstable, relatively speaking, compared to a knee with an anterior cruciate ligament. So those are my thoughts regarding that. I mentioned earlier in the program that surgery centers are open. Our surgery center in Exton is open for outpatient procedures. For joint replacements, we're not really able to do them yet, but certainly any arthroscopic or podiatric procedures, we're starting to slog our way through the backlog. So, all right. So I have been talking for about 50 minutes. I'm just looking to see if I've covered everything, and I think I have. And if there are no additional questions, then I think that I am going to wrap this up. I'm going to wait another minute, see if anyone else has got another question that they want to send through the chat line. Make sure I covered everything, but I like to think it was pretty comprehensive and answered pretty much any of the questions that you might have. So families and rehab, I guess I could mention a couple more things about going home. Going home is better. It's going home because you're in an environment that you're used to. All of your creature comforts are there. All your friends know where you live, so they'll come by and visit. Your family know where you are. They don't have to figure out what rehab facility you're in. And once they get there, what floor you're in. You don't have a demented roommate if you typically if you go home. Some of us that might not be accurate, but in all seriousness, family are generally speaking concerned, and it has a lot to do with the history of joint replacements. Since most people went off to rehab, people feel like, well, my neighbor went off to rehab when they had theirs done, and they feel like they're getting cheated a little bit if they don't go off to rehab. So, but that's really not the case. If we're controlling your pain and you're able to take care of yourself, home is just a much better, friendlier environment for you to recover in. And and there's a lot of anxiety. Well, is it safe to go home? And that's why we have these protocols in the hospital. And if you demonstrate you're able to do things that we need you to do, then we're pretty confident that it's safe to go home. And for anyone getting a joint replacement now, if you pass the criteria, you're not a guinea pig. We feel pretty confident if you do those things, you should be comfortable at home. And then, of course, the whole process from start to finish is a process of education, making sure that what to expect and who to call if you have a question or a problem or concern, and what to watch out for, and how to manage your pain, which is really the biggest anxiety that most people have. So I think with that, I've pretty much covered everything, and I will hopefully see you around soon. So thanks for watching.